Hello, everyone, and welcome to the Slightly Scientific Podcast. This episode is going to be a bit of a follow on from last episode, as today we are going to be interviewing Hannah Lunt. Hannah is a medical student and was allocated to a non-COVID A&E ward where her job was to see patients that didn't have any COVID symptoms. As well as this, she helped with the recovery trial that discovered that dexamethasone works well for people with COVID. And Hannah also joined the Johnson & Johnson vaccine trial where she trained participants and followed them up to see if they had any symptoms. As you can probably tell, I am really excited for this episode, and I hope you enjoy the interview. Our first question is, how did the recovery trial work?
So the recovery trial was amazing. It was as with so many trials, there are so many hoops to jump through in terms of like ethics and all that sort of stuff. So this trial was designed to be as easy as possible and like so easy to use, so easy to get involved in. And sorry, my Alexa's going off. So easy to get involved in. So what happened was when a patient comes into hospital and they are unwell, so they're needing oxygen or ventilation, what you can do is put them into, so you go into the website, the recovery trial website, and you can enter in all their details, all the relevant information, and it's so quick and easy, and it randomly allocates them to like a number of to like a category. So this could be they get no medications, so they're in the control group, or they get one of the other ones. So the ones that they're trialing out at the moment are this monoclonal antibody cocktail called Regeneron, which is a cocktail of antibodies that have been created just for COVID, and another one called baricitinib, which is a immunomodulatory drug that we use for rheumatoid arthritis. And so that's being trialed at the moment, and it's just cool. It randomly allocates patients to certain sample like subgroups, and yeah, we enter in all the details and it gets sorted out for us. It's so quick and easy. It's great.
How does I think dexamethasone help COVID patients, and what does it do?
Yeah, so dexamethasone is a steroid. It's a really widely used steroid. We use it for so many things, but steroids, as a sort of general rule, they suppress the immune system. So they dampen how much the immune system is having an effect on what it needs to be doing. So for COVID, we know that the people that are getting severely affected, they tend to have this thing called cytokine storm, which is where the immune system just goes completely out of control, and it secretes, so it produces all of these massive, huge amounts of cytokines, which are these little proteins that signal to the rest of the immune system that there's an infection going on, they need to fight it. So what dexamethasone does is it stops that cytokine storm. So it stops all these little proteins from being produced, and therefore the immune system sort of doesn't overreact as much, because that's where the danger with COVID tends to be, is that it seems to be the immune system damaging people's bodies rather than the actual virus damaging people's bodies. So that's why steroids like dexamethasone have been really, really great at helping people with COVID.
Really interesting. But do you know what long COVID is? And if you do, how can you diagnose it? Does it affect people very severely?
So long COVID is one of those things that we still don't know so much about. It is described as sort of lasting symptoms over like 12 weeks after someone has had COVID. So it's like a chronic condition. There's still so much that we don't know about it, but the most common things that people are presenting with are people that were previously completely healthy. They have COVID, and then a couple of months down the line, they are still so tired, or they've got brain fog, or they're really short of breath still. And they're still testing, they've started testing negative for COVID. So they don't have COVID anymore, but they are having really significant effects. So some people are struggling to walk up flights of stairs, and these are healthy 20-year-olds, and they're having to take a seat at the top of a flight of stairs because they're just so out of breath. Because again, everything is so new, we don't really know what causes it, but there's so many theories going around. I think the popular theories at the moment are that it's the lasting damage from COVID, because with this whole cytokine storm thing, the immune system overreacting, it damages these tiny little systems inside our bodies. So for example, in the lungs, COVID can the immune response can damage the little alveolar capillary membrane between the lungs and the blood vessels. So if that gets damaged, what happens when the body tries to repair itself is it can cause scarring. So we know that this scarring in the lungs can make it really quite hard to catch your breath, and that might be a reason why long COVID is persisting in people. But honestly, we don't really know what causes long COVID. It presents in so many different ways. There's like a new branch of clinics run by the NHS, which is like the long COVID clinics, which is basically a multidisciplinary team with occupational therapists, doctors, nurses, respiratory physicians, physiotherapists. So many people get involved to see what they can do to try and rehabilitate these people that are having lasting effects. So that could be things like getting them into lung physiotherapy so that they can like improve their breathing patterns again, that sort of stuff. So yeah, it's a load of unknowns, and at the moment we're like, people are just trying to tackle things as they come. But yeah, it's a strange one.
You said,
these long COVID,
sorry.
do these patients with long COVID, do they get a different treatment, or is it just the same?
So when they have COVID, or
do they get a treatment when they have COVID, or is there something for them after?
so there's nothing really that like predicts why someone might get long COVID. Like I said, you're getting really, really healthy people that can have lasting effects of COVID, and then sometimes you get elderly people that recover and they're fine again. So we don't really know what. It's nothing to do with the treatment. It's nothing to do with the severity of the initial disease. I think the current statistic is that 1 in 10 people diagnosed with COVID will have long COVID, so symptoms persisting more than 12 weeks. There's no treatment as such. It's sort of just supportive care. So if someone does have reduced exercise tolerance, then you sort of increase their fitness levels. If there might be input from a dietitian, if they're really drained, to try and like reboost their energy supplies in their bodies, all that sort of stuff. But there's no like one treatment that suits everyone at this point. It's just about rehab and supporting patients.
You said people get brain fog when they have like COVID. What is that?
So brain fog, it's a really weird symptom, and it's really subjective. So like lots of people might say that they've got brain fog and they might be experiencing different things. It tends to be sort of a lack of, so like loss of ability of like able to concentrate. So people are sort of zoning out of things. They can't follow conversations as easily. It can come and go. Like I know that one of my friends says that it's like he has this long COVID stuff, and he says that his brain fog, it feels like, you know, when you're underwater and you can hear things but you can't work out what people are saying. He says that when he gets these attacks of brain fog, it feels like he's underwater, so he can't really hear anything, and then it goes away within a few minutes. But like that was something that he never experienced before COVID. So yeah, so that's what brain fog is. Lots of people get it differently. You can get it, it's not just a long COVID thing. Anyone can get brain fog. But yeah, it's an interesting symptom and side effect of this infection.
How exactly did the Johnson & Johnson vaccine trial work?
Right, so I signed up as my elective because I was meant to go away for 2 months, and then that didn't happen. So I signed up, just sort of sent off my application, didn't expect anything to come of it, and then suddenly I got an email saying you're starting on the trial next week. So it was very fast paced, and I wasn't in it right from the beginning, so I don't know the full logistics of it. But it was the trial, the phase of the trial that we were doing was to try and ascertain any sort of side effects from the vaccines and if it was effective at all. So from the beginning, patients come in, they like signed up to a sort of database where they would say that they were willing to participate in vaccine trials. They then come in and get consented. They make sure that they've got their health is completely up to the level that we need it to be for the vaccine trials. So we can't have people that might be pregnant, people that might be immunocompromised, that sort of stuff. So these are all healthy individuals. And then they come through, and this is the bit where I met them. So they would come through and I would train them up on the things that they needed to keep an eye on. So any adverse reactions to the vaccine at the vaccine site, they would have to report their symptoms every Thursday to see if they had any COVID symptoms. And then if they did, then we would see them later on, down the line. But then we would like train them up on how to use this app and how they could enter all their symptoms in and track everything. And then then it was all kind of like top secret. We'd have to leave the room, and the unblinded nurses would come in. So these are the nurses, there's 2 of them, and they are the only people in the entire trial that know what vaccine, well, if the participant is getting the vaccine or if they're getting a saline injection. So that's the placebo. So they come in, they administer the vaccine. The participants then went out and waited in a like a waiting area for 15 minutes to make sure that they didn't have a reaction, like an anaphylactic shock or anything. And then we would like measure any inflammation or swelling of the vaccine site, and then we'd send them on their way. And then if they didn't have any reactions at all, we wouldn't see them again until day 57, I think it was, when they have their second dose. The Johnson & Johnson is now like, it's effective enough that I think it's a single dose now, but we were obviously giving 2 just to see if it made a difference. So then they get the second vaccine. They're still being followed through now. I think they get followed through the trial for a year to see if they do get COVID or anything like that. But yeah, it was really interesting. It was obviously an expedited version of the vaccine trial, so it was very quick, but that's because of all the funding that we've had because of COVID.
What precautions do you have to take when working with these patients?
So these were patients straight off the street, so they've not been isolating. There is a potential that they could have COVID. So we had to do the full barrier care with them. So that was visors, masks, gloves, and aprons. Not supposed to go within 2 meters of them either. So we were like, had these big rooms, they were on one side, we were on the other side. I think that was the hardest. So it was like full PPE. But I think that was the hardest thing, is that because being a medical student, like I'm in this industry because I really like patients and I like talking to people. So it was really hard not being able to do that because you have to keep a distance. So yeah, there were it was mainly just the space, keeping away from people. But I also got my first vaccine on the very first day, because if you're patient facing, you need to be vaccinated. So I got the Pfizer vaccine right at the beginning in January, which was great. But yeah, so it was just, lots of barrier nursing, lots of space between us, all that sort of stuff.
Yeah, that must have been like really weird for you to have to like try and talk to patients with all of your PPE and everything. Was it like harder to try and communicate with them and like explain to them what's happening?
It is so hard. It's the hardest thing. I didn't realize how much I communicate with just my facial expressions. So I'll be smiling at someone and they won't see anything because I've got a visor down to my eyebrows, so they can't see above my eyebrows, and then they can't see below my nose. So there's really nothing to go on. So I'd be smiling at people and they wouldn't be smiling back, and I'd be so confused. And then I realized it's just because no one can see each other. It's really, really difficult. It's also like when you're actually on the wards, being a medical student, we have all the time in the world to talk to patients and comfort them and reassure them. And that's like the best part about being a medical student, is you have the time to stay with patients. And with COVID, you just can't do that anymore. You can't touch a patient, you can't reassure them, you can't spend any time with them if they're stressed out. It was really difficult. It still is really difficult. It's completely changed the way that we interact with patients.
Actually, how long do you think it will be until you don't need to wear the PPE with patients anymore?
I think it's so difficult to say. I think it will be a case that we will always have to wear gloves with patients now. I think it will be a case where we will always have to wear masks if we're doing aerosol producing procedures. So that's things like ENT examinations, so ear, nose and throat. You have to obviously get the patient to open their mouth and say ah, and that is an aerosol producing procedure. I think that will always be the case, especially because I was reading earlier, I don't think there's been a single reported case of flu in 2021, and that's just because of all the masks. So like, yes, COVID is spreading, but nothing else is spreading. So I think especially with patients that have infections, I think we'll always keep PPE up for a long time. But yeah.
I mean, was it scary working with patients who could be like asymptomatic? Because I mean, you couldn't tell.
Yeah, no, that's my dog. It was really scary. You just like asymptomatic, what was it? I think it was 1 in 3 people don't have symptoms at all. So 1 in 3 people that I'm seeing could have had COVID and not known about it. And obviously, like as medics, we are like rehearsed in how to put PPE on, but a lot of the public aren't. Like lots of people don't know that you're not actually allowed to touch the outside of your mask, because that like makes it ineffective. And so many people don't know that. So even if they were wearing masks, there was still a chance that they weren't actually keeping up with their like social distancing and all that sort of stuff and infection control. So you just could like, there was just no way of knowing. And it was kind of like, it was scary. I'm also like asthmatic. So I was constantly on the lookout that, oh my God, if I get this, there's a chance that I could become quite ill with COVID. And again, I like getting like friendly with my patients. I'll sit down and spend 15 minutes chatting to them and like get them a glass of water and we'll like share a cup of coffee or something like that. And you just can't do that anymore. And it's just scary. It's really scary. You want to go and reassure patients, but you just can't do that anymore.
Was there enough staff and, oh, sorry, I think that's my dog there.
No, we should get our dogs on the camera together.
That'd be brilliant. Yes, that could be like the title. That could be like the cover of the podcast.
Yes, I would love that.
That'd be amazing. When you were there in the ward, were there enough staff and equipment? You know, how did you manage your time?
Yeah. So I signed up. The welfare representatives at Sheffield, they created this incredible scheme called the Helping Hand Scheme, where we all signed up and put our names down, and we were allocated to somewhere where we were needed. So I was allocated to a hospital near me. And one of the main reasons why they needed lots of medical students was because all the junior doctors were like redirected to the front line. So they were in A&E seeing actual COVID patients because that's where they were needed. So what ended up happening was the non-COVID A&E, which is where I was, didn't have any junior doctors. So it's all these consultants that have been out of practice for so long in terms of like taking bloods from patients, because that's not what they spend all day doing. So they needed juniors there. So that's what I was doing. So where I was, it was well staffed because it was the surgical teams that were running the unit that I was on, because all the medical, like the surgical teams, were much more useful with non-COVID stuff than the medical teams could have been. So the surgical team was the team that I was with, and we were seeing loads of things like appendicitis, cholecystitis, which is like gallbladder inflammation. We were seeing heart attacks. We were seeing like deep vein thromboses, so that's like a clot in the leg that can go up into the lungs. We were seeing loads of stuff that wasn't actually wasn't presenting as COVID. So things that we were pretty sure weren't COVID, we were seeing. And yeah, so I guess we were pretty well staffed where I was. It was a bit chaotic, but sometimes we would have to go into the actual COVID ward, and that was just, it was dystopian. It was terrifying. There were patients so unwell. There were so many staff running around trying to do their best. Like there have been staff members that have been working in the NHS for decades, and suddenly they've had to just relearn an entire way of treating patients. So everyone was a little bit frazzled. It was very scary. It was like walking into some dystopian film. But yeah, it wasn't fun. It was stressful.
That must have felt quite almost chaotic, I assume.
It was so chaotic. We also had so obviously we have to change our masks every 4 hours. So we had like a box of masks on the desk, and the boxes would go missing multiple times a day because people were just coming in and stealing boxes and then going home. So yeah, we were running out of PPE quite quickly, which wasn't great.
Yeah, I can imagine. When they separate people into the non-COVID wards and the COVID wards, do you know how they tell whether a person has got COVID or not?
So it's the cardinal symptoms would be the fever, the dry cough, and the loss of sense of taste or smell. If anyone presented with any of them, they were put onto a red ward or a dirty ward, which is basically, you might have COVID, we don't know, we're waiting for your test result to come back. As soon as they were put into that ward, they were given a COVID test immediately. if they didn't have COVID, then they were brought into a clean ward or a green ward. If they did have COVID, then they obviously stayed there until they were better. So yeah, that's how we decided. Obviously, if someone came in with a cough, even if we were pretty sure it was just a standard routine chest infection or a upper respiratory tract infection, nothing to do with COVID, we couldn't say that they weren't asymptomatically carrying it, so they would have to go into the dirty ward until proven clean.
Are there any particular experiences while working on the ward you want to talk about?
It's a great question. I don't think anything in particular. I think the main thing was just that it was so new for us as well. So I started working there in May. We'd only had about 6 weeks of COVID at that point, and all these patients were coming in so anxious, and they really, really needed someone to talk to. And their mental health was just shot already within 6 weeks of isolating. And now we're on 14 months, so not much has changed. But anyway, I think the main thing that hit me and that I won't forget is just the sheer anxiety that people came in with. They were just so nervous about everything. Sometimes they just came in because they wanted to chat. But we were also getting so obviously people weren't coming into hospital for minor things, but people weren't coming into hospital for heart attacks either. So there was a massive reduction in the amount of heart attacks that we were seeing in A&Es, which wasn't great because people don't just stop having heart attacks. So it means that people were having these heart attacks and they were too scared to come into hospital because they didn't want to be around COVID. So a lot of the time we saw people when they were presenting quite late. So I remember seeing someone with a heart attack who said that, oh yeah, I've been having these worsening symptoms for a while now, but I was too scared to come in. And he probably should have come in a good few weeks before that to get the treatment that he really ideally needed. So I guess that's kind of stuck with me, that people were at home suffering just because they were too scared to come in.
Wow, that's
really sad.
It was really sad. Yeah,
I'm kind of speechless now after that.
I know. I didn't think about it either. It was the same with cancer diagnoses. People were not coming in or not going to see their GP with things that were really quite sort of pathogenomic of cancer. And yeah, so cancer diagnoses did drop but that doesn't mean that they're not there. Cancer just doesn't stop being, people don't just stop getting cancer. So yeah, I think that's an effect of COVID that people didn't consider, but has been really widely acknowledged now and is really sad.
Yeah, wow.
Sorry about that.
No, it's really interesting because you don't think about that unless you're working.
Exactly. There's so many things with COVID that you don't think about until you see it. My mum is a nurse and she had a patient the other day. He was a 2-year-old boy, and she said that his face when he came into A&E was just, he'd never seen another human before outside of his own family, because he was born in the pandemic or just before the pandemic, before he could remember. And she said that he came into A&E and he was just astonished that other people existed in the world. And that's again something that we don't think about. There are so many little kids that have never met other people outside of their family. So yeah, COVID's weird.
That's amazing, the fact that it's weird to think about how you have, if you were born and you've never gone outside of your house and you just see all these people.
Exactly. I think it would be really interesting to look at OCD prevalence in about 10 years time to see if there's an increased prevalence or incidence of OCD in teenagers who grew up in this pandemic, because I'm sure being told to wash your hands 30 times a day is going to have some sort of impact on little kids, and they're probably going to grow up being quite scared of germs. And to be fair, growing up in a pandemic, everyone's quite scared of germs at the moment. So I think there's so many things that would be really interesting to look at further down the line. COVID won't go away.
Yeah,
it's really weird to think there are some children, probably even 4 or 5, that all they can remember is COVID. They can't really remember a time before.
Exactly. because like no one remembers things from when you're a little kid. So there are these literal small humans running around that don't know anything outside of the walls of their house. It's crazy.
So, thank you so much, Hannah, for letting us interview you. This episode has been truly moving, and it is especially fascinating when you get to see things from another person's point of view, especially something like the COVID pandemic, where we haven't really had the chance to see what it's like for other people. We had an amazing time, and I think one of the most interesting points for me was how dexamethasone works for patients, as I wouldn't have thought that suppressing the immune system would be useful when treating COVID. And thank you for listening to our podcast. You can reach us on Twitter at The Slightly Sci, on Instagram at The Slightly Scientific Podcast, or on our website, slightly-scientific.co.uk. I hope you have a great day, and see you next month for our next podcast. Goodbye.